Audio Jungle. Welcome to the Sports Review. My name is Alicia and I'll be your host for tonight. We go to breaking news right away. Olympic runner Sally Pearson has suffered a sickening wrist injury in today's 100-metre hurdles race in Rome. This race was always going to be fast and furious, with Pearson the favourite to win. Several moments into the race, Pearson fell on an outstretched arm and her wrist appears to have broken on impact. We have footage of the race now.
Stowers got away well there. Pearson not so well away. Rollins going well, and here comes Stowers on the near side. On the far side, Nelvis going well. Stowers, look at this, Nelvis on the far side in lane 2. What about that? What about that? 12:52. Pearson's gone down and is hurt, and she's obviously hurt her wrist.
Sally's fall was caused by a small calf tear. The champion hurdler says the pain of her severe wrist fracture didn't immediately register. Pearson heads back to hospital tomorrow for more surgery. The biggest hurdle she'll then face is being ready in time for the Rio Olympics.
Sally Pearson has broken her wrist. Unfortunately, the commentary there doesn't tell us much. The reporting from 9 News Gold Coast was aimed at a general news-watching population. While he did tell us that Sally has a wrist fracture and requires surgery for it, it doesn't give much insight into the actual anatomy of the wrist and what sort of specific injury she would have sustained as a result of falling on an outstretched arm at speed. So now we go to our panellists in the studio, Claire. Claire, can you shed some more light on just what happened?
Thanks, Alicia. Terrible, isn't it? Wrist and hand injuries are very complex and nasty and have long recovery times. As you can see here by the skeleton, the wrist and hand joint are very complex. First, to understand Sally Pearson's injury, and in layman's terms, let me demonstrate to you the hand joint and wrist.
The wrist is an intricate system of bones, joints, muscles, and ligaments. There are also nerves and blood vessels which supply the region. The bones of the wrist include the 5 metacarpals, which are the bones at the top part of the palm, and then the 8 carpal bones that resemble pebbles or stones and are arranged into the top and bottom rows of 4 at the end of the palm. The head of the radius is the larger and thicker bone that runs along your thumb. The other thinner bone is called the ulna. The wrist also has a pivot joint. That's when a rounded end of one bone, in this case the radius, fits into a trough-shaped surface of another bone, in this case one of the carpal bones. This allows for rotation of the wrist. The ulna does not participate in the wrist joint as it does not join up with the carpal bones unlike the radius. Surrounding the wrist is a fibrous layer called the joint capsule, to which several ligaments that help to strengthen and stabilize the wrist joint are attached to. When we look at Sally Pearson's X-ray or radiograph, we can see that Sally has significantly damaged her wrist. The bottom head of the radius is fractured or cracked and displaced towards the back. Several of the carpal bones have been fractured and displaced, and the ulna is also disjointed. This type of fracture is called a Cole's fracture and is most recognizable by the abnormal bulge in the wrist. In layman's terms, this can sometimes be called a dinner fork deformity. This will require surgery to pop the bones back into place, which might need some wires or pins, and a cast for several weeks. Sally would need ongoing physiotherapy to strengthen the wrist and regain some movement as well, and overall this injury could take up to a year to recover from.
For all the anatomy buffs out there, I wonder if our medical correspondent, Dr. Angela, can give us some in-depth professional insight on Sally's injury.
Thanks, Alicia. The wrist is a synovial joint that links the hand to the forearm. The bones and other structural components allow movement such as flexion, extension, abduction, adduction, pronation, and supination. As Claire said, there are 3 sections to the wrist. The first segment is formed by the pivot joint between the radius and ulna. The second segment serves as a link between the distal end of the radius and part of the ulna, and the proximal rows of the carpal bones, the scaphoid, lunate and trachea. The intermediate wrist joint in this links between the proximal and distal rows of the carpal bones, the trapezoid, trapezium, hamate, capitate and pisiform. The distal part of the wrist is of course associated with the distal carpal bones and linked to the 5 metacarpal bones.
The joint capsule and ligaments contribute to the stability of the wrist. The joint capsule is dual layered. The internal layer is comprised of a synovial membrane that secretes synovial fluid. This helps to lubricate the joint. There is a fibrous outer layer that attaches to the radius, ulna and the proximal row of carpal bones. In terms of movement, the capsule allows independent flexion, extension, radial ulnar deviation and pronation, supination of the wrist. Many ligaments help to stabilise the wrist joint, but for the purpose of time I will mention the 4 crucial ones. Firstly, the palmar radiocarpal ligament. This is found on the anterior side of the hand and passes from the radius and extends to both the proximal and distal row of the carpal bones. Another function of this ligament is to ensure that the hand follows the forearm during supination. The dorsal radiocarpal ligament is found on the posterior side of the hand and passes from the radius to both rows of the carpal bones. The ligament also ensures that the forearm follows the hand during pronation. The ulnar collateral ligament runs from the ulnar styro process to the tracheum and pisiform. This ligament works in conjunction with the radial collateral ligament to prevent excessive lateral joint displacement. Finally, as previously mentioned, the radiocollateral ligament runs from the radial styloid process to the scaphoid and trapezium and also prevents excessive lateral joint displacement.
Miss Pearson's injury occurred with the wrist pronated and in dorsiflexion, with significant force to the medial side of the hand, displacing and fracturing the ulnar, radius and carpal bones. Cole's fractures are typically sustained by landing on a flexed wrist and have distinguishing clinical features, particularly the tail bulge of the wrist. These features include radial shortening, radial angulation of the wrist and dorsal displacement of the distal wrist, which we certainly see here with Miss Pearson. The patient can often have an associated fracture of the styloid process of the ulna. There may be avulsion or tearing away of the ulnar styloid process, and thus the bone is pushed anteriorly. I have a few pictures that I can show you to help explain this.
The normal wrist range of motion is 65 to 80 degrees of flexion and 55 to 75 degrees of extension. The wrist can move on 2 planes, on the sagittal plane for flexion extension and on the frontal or coronal plane of motion for abduction adduction. Axial rotation of the hand is seen by the movement of pronation and supination, which involves the proximal and distal radio-ulnar and radio-humeral joints. Although not directly a motion of the wrist joint, supination and pronation are intrinsic for the function of the hand and wrist. The average normal range of pronation-supination is 160 degrees. After an injury, there can be considerable loss of wrist motion. However, it is still possible to perform daily activities. This is due to the compensatory motion of the bones proximal to the wrist. The patient can manage by using just 40 degrees of flexion and extension and with 40 degrees of radial ulnar deviation.
The wrist joint receives blood from branches of the dorsal carpal and the palmar carpal, which are derived from the ulnar and radial arteries. Innervation to the wrist joint is delivered by the branches of the 3 nerves: the median nerve that branches out to the posterior interosseous branch, the radial nerve that gives rise to the anterior interosseous branch, and the ulnar nerve which leads to the deep and dorsal branch. A Colles fracture could include median nerve palsy and post-traumatic carpal tunnel syndrome, a possible tear of tendons, such as the tendon of extensor pollicis longus and extensor indicis, as they extend across the carpal bones. The blood supply may be affected by injury, and this can threaten or alter the complex cycle of vasodilation or vasoconstriction. This disruption may cause progressive wrist or hand edema that can lead to stiffness. Furthermore, the patient may be more inclined to suffer traumatic arthritis at a later date. The sensory function may be impaired if there is damage or contusion to the median nerve at the time of the injury or the terminal sensory branch of the ulnar nerve that runs subcutaneously along the ulnar border of the wrist. There may be some numbness to one or more digits.
Did you happen to watch the sports review last night on Sally Pearson's injury?
Yes, indeed. Now, Claire, if you were the junior doctor on duty, how would you deal with this injury?
In order for us to diagnose a general fracture, as you know, we would need to consider a number of issues like the degree of dorsal angulation, the location of the impact, along with direction of displacement. In terms of angle of displacement, using the radiograph, we can separate the fracture into two groups, either minimal or maximum displacement. We will also need to determine the location of the fracture line, and if there's a presence of an intra-articular fracture, which are fractures that involve a joint space. Although AP and lateral wrist x-rays would suffice for a closed fracture, if there were concerns that there may be an intra-articular fracture as well, then a CT scan would be needed.
Great. Can you show me an example?
Yes, sure. So, what would be the best treatment?
Well, Cole's fractures and dislocations are usually manually realigned and then placed in the cast. However, if there is dislocation or displacement of the carpal bones and instability of the wrist joint, then surgery will be needed. Have a look at this radiograph. Such a procedure is called an open reduction and internal fixation, where internal fixtures such as screws, pins or plates are used to increase the stability of the joint. Can you see how the surgical pins and plates are placed post-surgery? Then, after the procedure, the wrist will be placed in a cast. The cast will be positioned inferiorly to the olecranon and extend to the metacarpal heads. It should hold the wrist somewhat flexed and in ulnar deviation. Minimal movement of the wrist for 1 week post-surgery is advised. Early mobilization exercises may begin 1 week post-surgery, but the first thing we would need to focus on would be reducing the amount of pain. We are looking at a rather lengthy rehabilitation and recovery period, I'm afraid, of up to maybe 1 year or perhaps longer to regain full strength and motion in the wrist.
So is it safe to say that Sally Pearson will need to use massage to prevent edema?
Yes, you're right. And with reducing edema, you can then observe the functionality of the wrist. The main priority will be to regain total range of motion in the wrist, and we should start to see this from up to 6 to 8 weeks. Following this, we should start to introduce muscle strengthening exercises to strengthen the muscles in the forearm, and then also the intrinsic and extrinsic components. Oh, is that the time? You should be getting off now. You've got that monotony.
Yes, exactly. I wonder what they let us do.
Thank you for watching tonight. We're all hoping that Sally Pearson makes a full and speedy recovery after that dreadful fall.